All right. So it is the top of the hour. So I still see people logging in, but we'll go ahead and get started. First of all, I'd just like to welcome everyone to today's webinar. This webinar is on the COVID-19 impact and how we can respond in the field of radiology. My name is Humphrey. I'm the Vice President of Technology Consulting for Canopy Partners. We are honored to have today some distinguished guests with us from both Radiology Partners and Canopy Partners. So I'll make some quick introductions here. First of all, if you are not familiar with the two companies, Radiology Partners is the largest physician-led and physician-owned practice in the U.S., serving over 1,200 hospitals and other healthcare facilities across the nation. Canopy Partners is a radiology consulting and IT services firm that's focused on elevating the role of medical imaging within the healthcare value chain. And the two organizations work very closely together, and we felt like there's a lot of things happening very quickly in the market right now that we would come together to develop this webinar for you all. The attendees for this call, it looks like there are almost 50 so far that have registered, are primarily hospital-based radiology executives. So that may be a radiology director, CMIO, VP of ancillary services. So that would be the intended audience for today's session. And again, we just want to welcome you all. Hope everyone is safe and well. Imagine most of you are coming to us from your home living room, your studio at home as well. We're all just trying to make do in the current situation. So I'm joined today by 4 speakers. We have Dr. Anthony Gabriel, who is, let me give a quick introduction. Dr. Gabriel holds a medical degree from Ohio State University and an MBA from UCLA. He is a co-founder of Radiology Partners, which was launched back in 2012. We also have Dr. Jay Bronner, who is the President and Chief Medical Officer, and we have Dr. Nina Kottler, who is the VP of Clinical Operations for Radiology Partners, as well as Saunders, who is the President of Canopy Partners. In terms of our agenda, we're going to cover 3 primary topics, and we're going to move fast. This is a 45-minute content with about 15 minutes for live Q&A. So we'll start with an overall impact of how the COVID-19 pandemic is impacting the field of radiology. We'll take a look at some of the data, the lessons learned, talk about the impact of volume and economics and policy. Then we'll move into the clinical impact of this, and then we'll talk about the operational impact and how radiology is adapting to this. And then we'll open it up for some live Q&A and then wrap things up. So again, thanks for joining us. Without further ado, I will hand over the mic to Dr. Gabriel, and Dr. Gabriel is going to cover the overall impact of COVID-19 in radiology.
Yeah, thank you, Reed, and thanks everybody for joining. So let's start just kind of really big picture here, and then I'll kind of zero into what's going on, what we're seeing directly at Radiology Partners. And as Reed was saying, we serve over 1,200 locations, actually closer to 1,300 locations right now across 25 different states in the US. And so we've got a pretty broad view of what's happening right now in imaging across the country. I know many of you on the phone might have a look at your market, at your facility or local facilities. So we'll kind of give you a sense of what we're seeing everywhere. But backing up a little bit, let's look at kind of how this started and where different countries around the globe are at. This is what I found to be a really good tracking site. The Financial Times has done a really good job and have made their COVID content available for free. And this right here just shows the increase in the number of daily deaths that are seen by different countries. And what's really amazing is just how many European and the US countries are so tightly together. What this is showing is countries, once they started having 3 deaths per day, it tracks them from that point forward in terms of number of deaths per day. And so you're seeing that they're all pretty tightly together. Reed, I'm getting an echo. I don't know if in the background you can check on that.
Yeah, keep talking and we'll clean it up.
Thank you, Reed. Mm-hmm. everything's pretty tight. If I could have the next slide. But the virus doesn't really understand country borders, right? The virus doesn't know about the borders between New York and New Jersey. The virus doesn't know the difference between northern Italy and southern Italy. And so if you kind of zero in, you can see on this slide, the different regions are impacted very differently. You can see the differences here between New York State and Washington State, quite different. You can see the difference between northern Italy and southern Italy, very different. So you can see that the virus is really attacking, and you see penetration rates, death rates, the number of infections different in different parts, different regions, different population centers around these different areas differently, which is why if there's any of you on the phone from New York, you know that while New York is really feeling the impact of this in a very different way than the rest of the country is. And right now you can see based on some of these other lines, which other markets might be coming to be like New York, and we have to start preparing for that, versus other states that look like it might not be as bad as New York. And so we're kind of all referencing ourselves against those different baselines. So next slide. Now, for all of us as healthcare professionals, you would expect a pandemic like this, lots of people getting sick. Oh my God, volumes are going to go through the roof. And although that is certainly very true for parts of the healthcare system, for many parts of the healthcare system, including imaging, that has not been the case. So right now you can see the volume of imaging that we've seen compared to what our normal baseline was. And you can see that we've gone down by over 50% at this point. We have started to see it level off. You can see these lines starting to level off, but we've gone down by over 50%. And from a financial perspective, if you look at the lower graph on this slide, you can see that the outpatient section has been hit the hardest. That outpatient section is almost 70% down at this point. And for us, like I'm sure for many of you, from a financial perspective, that has an even bigger impact on us than just a overall 50% volume, because our outpatient business, like for many healthcare systems, is actually the most financially revenue generating within the practice. We've actually been very surprised at just how deep the ER and inpatient imaging declines have been, with a nearly 40% decline in both of those two places of service, both in terms of emergency medicine and inpatient services. So really, really dramatic decreases that we've seen in imaging, again, flattening out now, and we're not sure when to predict that those are going to come up. So one of the things that we did on the next slide is we said, well, we need to be able to better understand and better predict what the impact on our imaging centers, on our radiology practice, what's that going to look like so we can plan for the future. And we developed 3 cases, a mild case, a base case, and an extreme case within a few days of the stay-at-home orders starting to impact the country in some states. You can see that we have actually changed that on this slide. The blue line is what we call our original base case, because things so quickly became worse than we anticipated that the base case is now the mild case. The green line is our new base case, which shows that 50% decline. And the extreme case that we modeled was a 70% decline. We did this, and I'd encourage all of you to start thinking this way, because we wanted to be able to better predict for our facility from a capacity standpoint, from a financial standpoint. We wanted to be able to predict this. You can see our base case has got about a 2-month period where we're in that trough. So you saw on the prior slide with what our volumes have started to flatten out. We anticipated that volumes would be flat. Our base case anticipates that they'll be down there for about 8 weeks or 2 months. The extreme case has them down there for 12 to 13 weeks. We're really not sure right now which one we're going to see. We're trying to downsize the capacity of our business in order to anticipate either one. We're kind of moving along in that trough. You can see we do expect that we're going to come out of this. And in fact, we're actually still modeling that we will not only come out, but for a period of time after this, have some supranormal amount of demand for outpatient services. We're expecting that. May not happen, but we are anticipating that. We did survey a large number of our radiologist leaders, people who run groups of imaging centers or lead practices in large markets, and surveyed them and found a median that they expect that only about 10% of the outpatient volumes would truly be lost for clinical reasons. In other words, cases, outpatient orders where the patient had spontaneous resolution of their medical symptoms, and so would not need to come back and get that done. So that means that a lot of the things that we're not doing right now, things like screening mammograms, for instance, people are still going to want to get those done later. And so we do expect that supernormal demand to come back. That's how we're thinking about this. Now, what we don't know, and I think none of us really know, if you watch the pundits, you can hear lots of different possible scenarios, but we don't know what the situation with people's insurance is going to be when this is done. We don't know how many people are going to be scared when the stay-at-home orders are lifted and still not want to come out. And so we can't anticipate those things. But from a clinical perspective, we know that that demand is still there, and that most of the outpatient volume that we've lost with that 70% decline that you saw, we do expect most of that, about 90% of that, will still be needed subsequent to the strict stay-at-home orders being lifted. We're going to have the next one. Now, I have to have a little bit of a bright side here. It's like, this is the, have we started to turn the corner here? And this is based on the data that's available publicly in terms of the number of new cases that we're seeing. We track this, both the dark blue line is the country, the lighter blue line is the market, the 25 states that we're in. You can see they're pretty close together. What this is basically showing, this decline here, is that the growth rate is slowing. It's not showing that the number of cases is slowing. It's just showing that each day we're not growing as fast as we used to be. So instead of the line going straight up, the line is going a little bit more gradually up. But we're still going up in most of the markets right now. But it does look like that we're starting to crest and hitting some sort of plateau in terms of the number of cases that we're seeing in our markets where RP is, as well as in the rest of the country. I can have the next one. So what to expect? This is really the kind of crystal ball that all of us wish we had. And I know ours is not working perfectly well right now, but we're trying to make as best predictions as we can. So first of all, the data from China. Via one of our board members, I had an opportunity to spend about 90 minutes with a senior executive in China who runs a pretty large business there. She has operations all over the country and was able to talk to me a little bit about what's happening there, what they're seeing. First of all, healthcare is come back, she said, very quickly. People are coming back, they're getting outpatient procedures done. Healthcare is rebounding very quickly, as is manufacturing. Those two things have both rebounded. In fact, she runs a significant manufacturing operation there and expected to be at 100% of capacity by the end of April. And so that's coming back very quickly there. On the other hand, services businesses are coming back, but a little bit more slowly. People are cautious. Also, in terms of the types of surveillance that they're seeing there, I know obviously the government has a lot more influence, a lot more control than here in the US, but she did say that there's something that the government has not mandated, but yet everybody uses, which is an application that's been put out that tracks if people are in COVID prevalent areas and will actually monitor your movements. And if you go into a COVID area, it will alert you so that you can avoid it. And it also tracks you and will validate that you have not been in a COVID area. And many stores and restaurants, although not mandated, many stores and restaurants are asking you to show that application when you walk in so that they have confirmation that you have not been in a COVID area. Certainly temperature scanning is highly prevalent there. They've done a lot of things like that. That may be something we see here. Again, we don't know. I'm just giving you data from what they're doing in China right now to inform you a little bit. And as far as for our operations, for all of us that are in healthcare, people are going to need to get outpatient procedures coming forward. There's only going to be so long that those things are going to be deferred. And so starting to think about what you might do with regards to temperature monitoring and infection control and things like that is important, and starting to make those plans for when we come out of that trough that we're all in right now within your organization, starting to think about what that might be. It's a little bit of a preview of where we might be going. As far as clinical volume expectations, we really think about it in 3 zones, the ER, inpatient, and outpatient zones. We are seeing already the first volumes that are starting to rebound are ER and inpatient. This is mostly right now in COVID-infested areas, the more prevalent COVID areas. We are starting to see ER and inpatient volumes rebound there, obviously, to take care of those patients. We do think that outpatient will probably be the slowest one to come back, with ER and inpatient starting to rebound first. Not optimal from an economic standpoint for any of our facilities, right? But it is most likely what is going to occur and how we have modeled this. Economic issues. I'm going to talk a couple slides in a bit about the government support that is available. But really important right now, going back to the modeling that I talked about a few slides ago, really important right now that from a financial perspective, facilities are modeling out what's going to happen economically to their facilities being in this trough. We're modeling a base case, as I said, of about 8 weeks. We may be right, we may be wrong. We're also anticipating it could be 3 weeks, or 3 months, excuse me, and that it could take a little longer to rebound. I think organizations today need to be prepared and be doing the right kinds of economic modeling for their organization to know where they're going to be in any of those different situations. And then the planning for future operations. I mentioned some of the things going on in China. I think we all have to be prepared to deal with patients in a area where infection control becomes significantly more important, and starting to make plans for what your policy and procedures are going to be in that area. If I could have the next one. I'm going to talk about 2 parts of the CARES Act. The CARES Act, I believe, has 8 parts in it, 8 different parts of support. The 2 parts I'm going to talk about are the parts specifically available for healthcare facilities and the part available for individuals. I know I'm not talking about individual support for all of you as individuals. I'm talking about it so that you can think about it appropriately as you're doing your financial planning. The government has stepped in with a pretty significant amount of support in the form of one-time payments and extended and additional unemployment insurance. It's something to think about as you're thinking about the need for labor. Certainly our first reaction here at RP was, wow, we want to protect our people. We don't want to do layoffs or temporary furloughs or anything like that, because we want to take care of our people. But as we did this analysis, what we found was that especially for our hourly workers, the government support covered the vast amount of their compensation. So much so that what we decided to do was we've stepped in, and for most of our hourly people are covering 100% of their compensation while they're on temporary furlough. For the people we've had to put on furlough from our imaging centers because of those decreased volumes, we're covering 100% of their compensation. And what that means is that we're covering the amount above what the government's taking care of, which leaves us with a small portion, but it saves the RP a lot of expense. And when our volumes are down 50%, we also have to be realistic. You know, we took a business and chopped its revenues by half in just a few days. And so we want to be able to make sure that we can withstand whatever length the trough's going to be in there. And we feel that we're still taking care of our people because of the fact that there's this tremendous amount of government support, and we're topping them up so that they get the same amount of pay at that for those hourly workers as they did before. There's a lot of other things that are happening I'm not going to go into. The next piece on the next slide is that $100 billion is available for hospitals and healthcare groups. We are still working to get guidance, and we'll try to get it out to this group as soon as we get more guidance on it. It's still pending right now. So there's still more questions than there are answers as to how this money will be distributed. But certainly we intend to take advantage of it. We'll get you guys information as it becomes available. And it sounds like, based on the information we're getting from people in DC, is that there will be another bill that will be coming out, which is likely to include more healthcare support. And I know that a number of healthcare facilities are being financially impacted significantly. So thanks. I'm going to pass it off to Dr. Kottler and Dr. Bronner to talk a little bit more about the clinical impact.
Thanks, Dr. Gabriel. I'll advance a slide here as I'm doing that. Just a quick question. How do you think this pandemic is going to change the way we practice radiology in the future? Do you have any crystal ball as to long-term impact?
Well, I certainly think that imaging and how we do imaging, if we think about this broadly, is going to change significantly, right? Because the kinds of infection control measures that we need to take are going to be different. We have to think about what scanner capacity is going to be, because we won't be able, the things that we'll have to do in between patients are going to take much longer time. So that could be impacted significantly. I think those are a couple of the really big areas. As far as the interpretation of images, I'm actually going to leave that to Nina and Jay to talk about a little bit.
Sounds great. So Dr. Kottler, I believe you're up next, and we're going to talk about the clinical impact that we're seeing.
Thank you. You can go to the next slide. Oh, just an acknowledgement that I found a lot of great information through UCSF. They've got a great grand rounds and a link. You should all have a copy of this, but a link to their grand rounds is here, and I use some of their slides. Next slide. So today, Jay and I are going to talk about, well, I'll start off just talking about the basics of the disease, transmission, and how contagious it is. And then Jay is going to continue from there to talk about imaging considerations and reporting. Okay, so just to level set, next slide. The clinical entity that we're seeing of COVID-19, which just stands for coronavirus disease 19, it comes from the virus SARS-CoV-2. That virus is part of the coronavirus family, and then that coronavirus family is also the virus that caused SARS, which came out in 2002, MERS that came out in 2012, and the common cold. The coronavirus family causes about 20% of the viruses that cause the common cold. And from a genetic makeup standpoint, the SARS-CoV-2 virus that we're seeing now is most similar to SARS-CoV, which is the virus that caused SARS. And there's some good information about that. First of all, we've got a lot of information about the SARS-CoV virus since it happened in 2002. There's a lot of data about how it was transmitted and what the virus looked like. The other part is that from a standpoint of immunity, the immunity to the common cold viruses and the coronavirus is actually short-lived. It's only about a year or two. And the immunity, however, to SARS is a lot longer. So we're hopeful in the community that the immunity to SARS-CoV-2 will be a lot longer. Okay, the structure of SARS-CoV-2 is that it is, if you can just go back one, it is an envelope virus. And that envelope virus has internal genetic material. That genetic material is a single-strand RNA, and it is surrounded by a lipid membrane. The little red things coming off the outside of the membrane are called spike proteins. These spike proteins are what give it the crown-like appearance, and such they name for coronavirus. These spike proteins bind to receptors. They're angiotensin receptors in the nose, mouth, the lungs, but also the eyes, GI tract, and other places. And because it binds in these places, it's very easy for people to get infected. So notice that there's nose, mouth, and eyes. So anything where you're touching a surface, hands to face, are dangerous zones because you can get that virus directly into your cells. What's interesting is that the number of the receptors involved, they increase with age. There's very low expression in newborns and young children, and that may be part of the reason why we're not seeing a lot of disease in the very young. Next slide. Okay, so viruses in general, they are unlike bacteria. They are not living things. And when I say they're not living, it means that they can't reproduce on their own. They actually need to infect one of our cells in order to reproduce. And they do that through our mucous membranes. Again, there are the receptors in both the eyes, nose, and mouth. So how do you get rid of it? Because it is dangerous to touch a surface and then touch your face. We want to make sure that our surfaces are clean. And envelope viruses in general, which this coronavirus is actually really easy virus to kill. Soap on its own will literally rip it apart. You can see on the images to the right, it shows how soap attaches to the lipid membrane and then just literally breaks the envelope apart. but you have to do soap for 20 seconds. You have to wash your hands for that amount of time. If you are washing your hands for less time, the virus is still going to be present on your skin. Other things can be used are different kinds of disinfectants, anything with more than 60 or 70% alcohol content, anything with bleach, hydrogen peroxide, and actually UV light does a significant job in killing the virus. There's a list of disinfectants that's produced by the EPA, and there's a link to that here. So if anyone needs to know what they need to use to, for instance, radiology, there's a list here. Next slide. And next slide. All right. So transmission, we think the vast majority of transmission is through droplets. Someone sneezes, someone coughs, and there's droplets that have weight that get expulsed from that, and they drop to the ground. That's why we're doing the 6-foot social distancing, is because most of those droplets only are around for the first 3 to 6 feet, but they will stay on surfaces as well. And the different surfaces have different half-lives. Metal, copper has the shortest, cardboard a little bit longer, and plastic actually has the longest. Now the times that are on here, so plastic 72 hours, that's the time to have 0 detectable virus left. There's significant amount of decay of the virus prior to that. So by the time you get to about 24 or 48 hours, for most any surface, the amount of virus that's actually on that surface is significantly decreased. However, there's also discussion now about aerosol transmission of disease. People singing, talking, breathing, and certainly in the hospital procedures that are being done, that can produce aerosolized virus. And aerosolized viruses stay in the air for a lot longer period. They're not as weighted down, so gravity doesn't pull them down right away. And it means that they can be, because they're also smaller particles, they can be inhaled and go more deeply into your respiratory system. The most virulent viruses tend to be aerosol viruses. So things like measles and TB, those are extremely virulent. They're spread mostly by aerosol. COVID-19 or SARS-CoV-2, we think is mostly spread by droplets, but we do have to be careful, especially in the hospital where we are doing procedures. Any procedure that can induce coughing has the risk of creating aerosol in procedures. Also CPR and intubation can do that as well. So masks were recommended now by the CDC for everyone. I'm in San Diego and it's mandated that people wear masks if they're in a public space. If you can click to the next button and the mask will hopefully come down. Oh, you can go back one. The masks are actually there not to protect yourself from any aerosol. The masks that we're using are not protecting for aerosol unless you're in the hospital using a specialized mask. Really what they're meant to do is decrease the transmission, because most of it, as we think, is droplet transmission. If someone sneezes, coughs, sings, talks, or breathes, then some of that is going to come out and the mask will help protect everyone else. Next slide. So how contagious is SARS-CoV-2? The reproduction number is a number that's often used to determine the contagiousness of a disease. And the reproduction number is called the R0. And the R0 of SARS-CoV-2, we think, is somewhere between 2.2 and 3.6. So what is the R0? The picture underneath shows an R0 of 3. And it means that it's the amount of disease that one person can give to another person in a general population. So here, this one person would give the disease to 3 additional people. Once you get above 1, you have the ability to create an epidemic. If one person is giving it to even 2 people, the disease can spread exponentially. And here we think it can be even higher than that. Next slide. So what is the R0 of COVID-19 in comparison with other diseases? If you compare it to something like measles, which we said was mostly spread by aerosol, it's a lot less. See, the R0 is closer to the R0 of SARS, which again, we know it's genetically similar to the R0 of SARS. But in SARS, the epidemic was not quite as great. There were only about 8,100 people across the world that were infected with SARS. And in the US, there were only 8 known positive cases. So why is COVID-19 affecting over now 1.3 million cases worldwide? Next slide. So is it that the amount of viable virus is staying longer on surfaces? And here's a graph on the right of comparing SARS-CoV-2 in red and SARS-CoV-1 in blue. And you can see that there's about a similar amount of virus on the plastic surfaces. So the answer to that is no. Next. What about an aerosol? If you do the same thing, you'll see that the amount of SARS-CoV-2 is actually a little bit less in aerosol than SARS-CoV-1. So the amount of viable virus is not greater. Next slide. What about its staying power on these surfaces? So they stay longer on plastic than it does. I am hearing an echo. So I will keep going, but read if there's anything you can do in the background. So does it stay longer on surfaces? No, it's actually very similar. And what about on aerosols? Does it stay longer in the air? And that's also no. So what is the difference then? Why is SARS-CoV-2 or COVID-19 affecting so many more people than we saw with SARS? And one of the thoughts now is based on this graph. If you look, this graph on the x-axis shows the days since onset. So 0 is 0 days of your first amount of symptoms, and the y-axis is the viral load. And you can see in the beginning of disease, very early on, if you can hit next, that the COVID-19 has a huge amount of viral load very early on in the disease. As opposed to SARS, the maximum excretion of virus at SARS did not happen until day 10 after symptoms. And by day 10 of symptoms, people were isolated. We were able to have control methods to make sure that those people were not exposing others. In the case of COVID-19, people very early on in the disease where their symptoms are mild are excreting a very large amount of virus. And so they're very contagious at a time when they might not know. And if you click one more time, the other thought too is that prior to symptoms, there is also a high viral load. And there are some cases of asymptomatic carriers that have a viral load. So these people who are walking around that don't have symptoms are able to shed and excrete the virus. And that is causing the contagiousness before we know about it. And it makes it a lot harder for us to control. Next slide. All right, so what is the treatment going to be for our very sickest patients? Well, in the first week, if you click to next, again, we talked about having a very high viral load during this time. The amount of cytokine and immune response that we're getting during this time is lower, and symptoms are just beginning to evolving. So click next. So the treatment during this time is really to have something that is attacking viral replication. So an antiviral treatment is the treatment of recommendation during this first week. Once people get into the second week, symptoms start to evolve. The viral load actually declines, but some people can get an acute respiratory distress syndrome, an ARDS type syndrome. And that kind of syndrome comes from a breakdown of the barrier between the alveoli and the vessels, the capillaries that are exchanging oxygen between the airway. And when those areas break down, the ARDS syndrome can occur. And that's when you see an image like you do on the right, where there's a lot of white out of the lung and a lot of disease in the lung. And we don't think that is because of the viral load, because at that time, the viral load is decreasing. And what we are thinking, it is more likely related to a cytokine response. And cytokines are part of our immune function. They're basically the messengers of the immune system. They're telling the immune system when to turn on. And when you get a high cytokine response, you're going to get a very big immune reaction. So we actually think that ARDS is immune mediated. So in this time, instead of using an antiviral treatment, we think the best treatment is more an anti-inflammatory or a cytokine modulation treatment. Thank you.
Dr. Kottler, just a question about that. You mentioned a strong immune response in the second week of the disease, which could lead to acute respiratory distress syndrome. So the body's trying to fight it off. The immune system is almost in an overdrive, and that can create a lot of inflammation. So you would think that an anti-inflammatory, a corticosteroid, or an NSAID would help to treat that. But we're also hearing that those may actually have an adverse effect or not be effective. So how do you reconcile the two when you're providing treatment?
Yeah, that's a really good question, and a question that we're struggling with a little bit. There has been some reports out of France that NSAIDs worsen the course of disease. There's been a bunch of studies about the use of general corticosteroids, and have found that that can also worsen the course of disease. So why would that happen? The immune system is a system that is meant to help us. There's two components of it. The first component of the immune system is the part that happens immediately. And the goal of this is to decrease the replication of the virus. It is not specific to the virus. It's based on cells that are always moving around in our blood system. And so they're trying to decrease the amount of viral replication. So it's really about walking that fine line. How do you make sure that your immune response, which is decreasing the viral load, is helping us but not hurting us, because it can also injure the capillaries and the alveoli. So it's about containing the right amount. And it's a fine line that we haven't quite figured out yet, but we're trying to walk. What we're looking at now are certain cytokine modulators like IL-6, interleukin-6 is a type of cytokine. And we're thinking about medicines that can attack those specific components of the disease, but hopefully more to come in the next couple of weeks. Thank you.
Great, thank you so much. Dr. Bronner, I'll tee you up and just let me know when you want me to advance the slides.
Go for it. Well, I'm going to shift gear a little bit and talk about the clinical aspects of COVID-19 as they relate to imaging. And I think everyone is aware that in the middle of March, the ACR came out with a recommendation saying that that non-urgent imaging should be suspended or delayed to a future date. And the reason for that was, as we started to understand the significance of social distancing, it became aware that this was really a safety precaution that we could use to prevent the spread of the virus and to protect patients who are coming in who are symptomatic for other reasons, or to prevent transmission to the staff. So things such as DEXA screening or screening mammograms or routine image, just general routine imaging that could be for following up what's felt to be most likely a benign finding, was suggested should be delayed and not scheduled during the intervening 4-week period. And as Anthony mentioned, Dr. Gabriel mentioned, we have noticed a significant decline in our volumes as a result of that recommendation and our implementation of that across many of our practices and many of our imaging centers, where we are now we're in that trough of volume as was described before. There were also some protective actions done for and recommendations made for how to protect healthcare personnel, because it was realized early on that having a healthy healthcare system was going to be critical for the reduction in the overall number of deaths that COVID-19 inflicted upon our country and the world. So things such as managing the droplet spread and using masks for patients who are PUIs or patients under investigation for COVID-19, and cleaning of equipment as they are come into contact with patients is something that was begun really early in the process to manage the droplet spread. Also, in events of really critically ill patients or patients where there could be an aerosolized procedure, such as bronchoscopy or intubation, a more higher level of protection was necessary. You can see the link, which was included on the slides, to the SIR guidelines, which basically states that you should be using a mask that is of a higher level of protection And that would be the N95 mask. I'm sure all of you are familiar with. Next slide, please. So what is the role of imaging in COVID-19 evaluation? And in thinking about it, I want to talk about three modalities: portable chest X-rays, chest CTs, and chest ultrasound. What was written about really early on in anticipation that people were going to be confused as to how to use imaging was that chest X-rays and chest CTs were not general screening tests for COVID-19. And the reason being, there's very little impact that the chest X-ray or the chest CT is going to have, except for when cases where the clinical findings and the diagnosis just don't seem to match. So one of the reasons why chest X-ray in particular is not considered a good screening test is there's a wide range of sensitivity, the ability of the test to detect a disease that ranges anywhere from 25% to 70%. Neither of those boundaries are really acceptable for a screening test. But if a chest X-ray is needed for some extenuating circumstance, if there's some reason why in the acute phase you want to get a chest X-ray, ACR recommends that portable chest X-rays be used as opposed to transporting the patient to a location where the chest X-rays would be done. Chest CT, on the other hand, has better sensitivity than chest X-ray, up to 84% if you wait to days 3 to 5, and specificity in the 60 to 70% range. So there is a clinical use for chest CT, particularly in patients when there's a rapid decline in patient status, or if you're trying to exclude another condition which may have a characteristic finding on CT, and there'd be an opportunity to differentiate the two. The bottom line being, if there's a change in patient management, CT scan does make sense with the protection that we talked about before by having patients wear masks and cleaning appropriately between procedures. What's come out, and what I think is really pretty exciting, what's come out in both Europe and in Asia, particularly in China and South Korea, is that lung ultrasound has a lot of promise in the management of COVID-19 and COVID-19 pneumonia. And we don't normally think about ultrasound as it relates to lung disease because, air doesn't transmit ultrasound waves really well. And what's the lung full of? Normally air. But it turns out as the infiltrates or the pathology in lungs in COVID-19 tend to be peripheral, that is an area that the ultrasound can actually see real well. And it could be done at the bedside. And this is done as a portable exam at the bedside with pretty simple technology. And I'll show you an image of what that looks like. And is very promising in being able to detect patients for COVID-19 findings, both inside the hospital, even before they get to the hospital, or once they've been discharged. So a lot of promise coming about that. And there's some guidelines as what you might do if you want to consider using it in your facility. Next, please. So what does COVID-19 look like on our imaging studies? And the best one to look at is CAT scans. And here you can see a CAT scan of somebody who has fairly advanced signs of COVID-19 pneumonia. And early on, they're up to 15% of the time in the first 5 days, it could be normal. But the hallmark, and you'll be hearing about this if you listen to clinical discussions, is this infiltrate, which is the fluid that's in the lungs as a result of the inflammatory response developing, has a ground glass appearance. Now, what does ground glass mean? It means that you can actually see through it, and you can see the lung vessels and the normal structures through the density. So that infiltrate with the asterisk on it, it's a good example of ground glass in that you can see the underlying vessels and airways in there. Day 6 to 11, as the disease progresses, most of the CAT scans are going to be abnormal in people with COVID-19 pneumonia. And that's where you're going to see the maximal lung involvement with increasing consolidations, more infiltrates. And then finally, in the resolution phase, after about 2 weeks' time, you may see sometimes an increase in the ground glass going from the more diffuse consolidation, and then ultimately resolving within 18 to 24 days. Next slide, please. So as a practice, we tried to make recommendations to our radiologists, and did this in a collaborative way with practices across our practice on how to report the findings of COVID-19. Our goal was to, on one hand, convey meaningful information, on the other hand, not cause a lot of panic in environments that weren't seeing COVID-19 yet. So in the outset, we started out with making the recommendation of viral pneumonia, and this came about through recommendations that appeared through the ACR, not using COVID-19 as the diagnosis, but more referring to viral pneumonia. Later in the month, at the end of March, a general consensus statement came out through the RSNA, ACR, and Society of Thoracic Radiology that recommended that we use a standardized nomenclature and standardized lexicon for reporting COVID-19, so that we'd be able to reduce the variability in what our radiologists were saying and how we were communicating to the clinicians, but give the advantage, and we as a practice decided to give the advantage of flexibility to the local hospital environments, where when they're not seeing cases of COVID-19, to use viral pneumonia where they are in our larger urban centers, or centers around Chicago, New York, and Florida, use COVID-19 as appropriate. And there are basically 4 different categories of reports that we have templates for, and we're happy to share those with you after the webinar. Have the next slide. So again, let me go briefly into lung ultrasound, an exciting new technology, something that has been shown to have a lot of clinical application, and it is able to diagnose lung disease peripherally in COVID-19, and that's really where it shows up in the early and mid phases of the disease, and it's very sensitive for it. Studies have shown that it's more sensitive than chest x-rays and serial exams. And as I mentioned, it's been very effectively used in Asia and Europe because it's safe, reproducible, doesn't involve radiation, meaning you can do it in facilities before patients even come into the hospital. It's low cost and it's fairly easy to train. Next slide. So how can we use it? We can use it as a screening test in outpatient settings and the emergency room. And the same person who comes in contact with the patient doing other procedures, be it doing the physical exam or triaging the patient, has the ability to do this test too. So it could reduce the number of people that need to interact with a patient who's a PUI, and that has significant health impacts for the system as a whole. It allows triaging in a very quick way, and it allows you to monitor the response to therapy and manage the patient in the hospital as an inpatient, and be able to predict who may need ICU treatment, and I'll even give information as to when somebody may be up for being a candidate for weaning off a respirator. And I think we've all seen in the last 24 to 48 hours, there's been lots of patients who's starting to come off respirators and help in post-discharge management. Next, please. As I said before, it's a really simple bit of equipment. It's basically a probe, a cord, and it connects to a tablet or an iPhone. So it really can be very easily protected from a shielding perspective and a sheath perspective as far as making sure that it can be effectively used from patient to patient just by changing the protective sheath. Next, please. Easy to do, takes about 8, we use about 8 locations in doing it, 4 anterior and 4 lateral, 2 on each side. Next. And what it does is it changes the, what we see is a change in the normal pattern of a chest x-rays. And these are the A lines on the left-hand side of the screen, which are these horizontal lines that are representing normal air. And from the A lines, you can see a much more vertically oriented B line pattern, where there is a sharp interface between a skip area and the affected areas. And it's been shown that these B lines actually represent the infiltrates we're seeing on the chest x-ray. Next. So what do you need to do in your facility in order to implement this? Well, there's obviously a communication that should take place between key stakeholders, emergency room physicians, intensivists, pulmonologists, radiologists. Figure out the best way of actually providing this as a point of care service, who should be doing the procedures. You can discuss this at medical executive committees or whatever your appropriate clinical care committee would be, and then decide who should interpret them. And that's obviously something that can be done. The procedure can be done by one group and interpreted by someone else. It's important to educate the clinicians and the radiologists in the findings of lung ultrasound because in COVID-19, because it's not something we've ever seen before, and to train our technologists, if technologists are going to be performing this service, or the other personnel who may be the ones doing the primary interaction with the patient in the triage setting in order to be able to accomplish this. And then finally, utilize full PPE when doing this, because we're going to be within a short distance of somebody who could be a PUI. So face masks, eye protection, gloves, and gowns. So in summary, what we talked about is COVID-2 is a virus that's easy to kill, but it can be very infectious, and people who are infected can be infected and shedding the virus with no symptoms. It's mostly spread via droplets, but there is an aerosol component, and that imaging studies are not necessarily, should not be used as screening studies, but a point of contact of care ultrasound could be very useful as a screening tool. And multiple societal recommendations have made the suggestion that we use a standardized lexicon in reporting the findings so that we can reduce the variability between inter observer and communicate the findings clearly. I've attached some useful websites to view as references and the subjects that they're discussing.
Great, thanks, Dr. Bronner, we appreciate it. We're going to transition quickly to Worth Saunders, the president of Canopy Partners, and Worth is going to cover the operational impact. And Worth, we've got maybe 5 minutes, and then we're going to open it up for Q&A. So I'm going to challenge you to talk quick, okay?
Okay, thank you, Reed. I appreciate it. Thank you, everybody. Just a few comments on technology and operational impacts that we've seen as a result of the COVID-19 time period. The first area I want to talk about is regarding remote reading. This is a common theme that we're hearing, is the desire for radiologists to be more flexible in terms of where they can provide their professional interpretation services during the COVID crisis. Initially, it was to offer a place for radiologists who may have traveled to areas of concern, and it's kind of transitioned over the last couple of weeks to be able to provide a remote reading location for radiologists who need to stay out of possible exposure to the virus, or may have been exposed but still are able to work. In terms of short-term strategies we're seeing in this regard, one is a reading bunker. Basically, this is utilizing existing offices, maybe an outside reading office that the radiology group has already established, or a business office, for example, that has connection to healthcare facilities. This can be used to quickly set up reading rooms for the radiologists, and particularly can be done in light of many non-physicians, office staff working remotely from home. So typically these already have high-speed connectivity, and so they satisfy a lot of the security concerns as well by already having connections to healthcare facilities. So definitely a reading bunker utilizing existing office space is a quick way to establish remote reading space. Second strategy we're seeing is setting up home reading stations for radiologists at their homes. Some groups already have home reading stations, so this flexibility is already embedded, but others are quickly trying to procure reading stations to allow radiologists to work at home in addition to providing services on site when they need to. We see that the optimal long-term solution, which really has come to light during this crisis, is to establish what we call a unified radiology platform. That's basically a system where a radiology group can read out of a single PACS, single voice recognition, single work list, so that they can organize their work across their whole enterprise that they provide services to, often disparate healthcare systems and facilities. This, when this is done, this really allows the group to pivot quickly and to provide flexible solutions in times like this. So I'd really encourage everybody to think about working with your IT staff and facility management to do that, because it really can provide some great flexibility. For example, one group that we work with, in less than 2 weeks, they're going to have 9 additional read stations deployed at home, and next week they'll have an additional 11 for a total of 20. So quickly spinning up 20 home read stations and office-based remote read stations can only be done if you have the infrastructure in place to begin with. Another consideration at the bottom there is a call center. This is being employed by multiple facilities to keep the workflow smooth during times of crisis and during regular times as well. And these reading room call centers have been set up to facilitate communication both inbound and outbound, trying to find radiologists to answer questions and provide consults, as well as communicate results. So this can be done typically remotely as well, so that the work can continue to be done in a smooth fashion. Next slide, Reed. Just a few considerations from an operational standpoint, and the last slide in the packet is basically a diagram that we have put together at RP and Canopy to provide some categorization of the different outpatient procedures. We categorize these into high priority, medium priority, and low priority, basically, in terms of needing to be done, specifically for each type of typical outpatient imaging exam. So you might use that as a reference point in terms of scheduling what needs to be scheduled during the COVID crisis, and as a reference as we kind of get into the transition phase post-COVID. I'll also say that some things to keep in mind. It's not too early to start thinking about the rebound post-COVID. Keep a database to capture patients that might have been deferred, that weren't able to be seen in the last month or so. You can call back these patients if you have them on a list. Start thinking about additional hours of operation. As Anthony mentioned, it's a good possibility that there will be a supernormal rebound, at least for a period of time. So think about it, additional hours of operation, as well as use this as an opportunity for process improvement. That we've all had to get very creative and innovative. Cross coverage that we never thought we had to do has been employed. So use that as opportunities for long-term process improvements and efficiencies as well. The last comment I'll make is just about supply and demand of radiologists. I think the significant volume decreases that we've seen, I think at least in the short term, will create a different dynamic in terms of supply and demand, basically the recruitment environment for radiologists, which leading up to this COVID crisis has been extremely tight market to recruit radiologists. So at least short term, we see that easing up a little bit, and until we go back to the volumes that we saw before. So thank you, Reed. I will use that diagram that I pointed to as a reference. If anybody wants to use that, it's in the last slide. Thank you.
That's great. Thanks, Worth. You did a great job of delivering that in 5 minutes. Nice work. Okay, so this brings us to the Q&A session, and let's make sure we do this in a good way. There in your panel, the GoToWebinar panel, there is a place for questions and for chat. You can use either of those just to submit an online question. You can also unmute your audio and ask a live question to anyone on the panel if you wish. And Joey, who's working the audio controls behind the scenes, Joey, if you can kind of enable that so that people can unmute themselves if they'd like to ask a question. And I'll start with a quick question just to get things going. Worth, since you were the last to go, you mentioned that the radiology groups have to have the right infrastructure in place to be able to work remotely, and specifically a unified radiology platform, which would allow a radiology group to, read across multiple facilities. Maybe they read for 2 or 3 hospitals and a couple of imaging centers, and to be able to see everything and share the workflow I don't know how many radiology groups have that out there, but that sounds like a pretty advanced thing. And how should the hospitals feel about that if the radiology groups are wanting to run things on their systems and sort of centralize their reading platform, because the prevailing norm is to read within the hospital silo on their system. So how does that change the way of thinking between the rad group and the hospital?
Well, I think it is definitely a very collaborative process in terms of utilizing systems that are both the long-term archive, for example, for PACS, as well as the reading systems that the radiologists use for interpretation. So the definition basically underlying the unified radiology platform really is all studies from any imaging facility, outpatient or hospital-based, along with the HL7 orders and demographics, are basically sent and forwarded to a single common system that allows the radiologist to read out of that single PACS, single voice recognition system. So it really, the results and outcomes of that is ability to subspecialize more, provide faster turnaround, as well as enables 24/7 final reads much easier. So it really enables a higher level of service and quality that I think everybody is searching for.
Okay, great, thank you. I'm going to try to take a couple of the questions that we have here, and if anybody has any live questions, let's go there first. Assuming we were able to get it unmuted, does anyone have any live questions they'd like to ask our panelists? Okay, so here's a couple of the questions that we've had come in. So Dr. Bronner, you mentioned using lung ultrasound as a way to kind of do screening for COVID-19. Can lung ultrasound be used outside of the hospital? And if so, how would that kind of enhance the continuity of care? I think we've got you on mute.
Lung ultrasound can be used in a primary care office and by a primary care physician, for example, or in a screening center before somebody would actually come to an emergency room. A myriad of outpatient locations could perform the test, because again, all that's necessary is a probe, a cord, and the attachment to an iOS device. And then those images could be compared for change to see increase in disease, and then finally in the hospital, and can be used as a discharge when a patient is actually sent home. In Europe, they use the ultrasound in a way to follow patients' resolution of disease from with a patient or a family member actually holding the transducer up to the chest wall and using it in that setting. So there's a whole myriad of in the continuity of care that ultrasound could provide because of the simplicity of the equipment involved and needed.
Okay, that's great. Dr. Gabriel, in terms of the long-term forecast of this, you showed the dip and then the recovery. Do you think that surge is going to be significant later this year? And if so, is the pendulum going to swing so hard that we're going to go from this lull and radiologists have been sent home to all of a sudden we're going to need all hands on deck and bailing water at a faster rate than we would normally be for some period of time? Is that what you're projecting?
Well, I wish I had that crystal ball, Reed, to know exactly what's going to happen. Again, I can tell you this, that we operate about 110 imaging centers right now, and many of them are scheduling patients for off in June or late May, and those schedules are very full right now. We have not made a decision to actually how we're going to operationalize them, but those schedules are packed. And so that tells me that there is this latent demand that's going to show up later. Now, I think the part that is really hard, as I was mentioning before, is there's obviously tremendous economic impact. I mean, we've just had 2 weeks in a row of the highest number of unemployment filings ever in the history of our country. What is that going to mean for people's ability to pay for healthcare, for outpatient healthcare? I think that's very hard to predict right now. I'm very hopeful that the government comes in with some additional support for people to be able to continue doing that. but I just really don't know. I do think there's going to be a lot of clinical demand for supernormal utilization, and we're certainly preparing for extending hours and preparing for adding shifts after this is done. So
great. Okay, so we're a little bit over on time, so we probably should bring this in for a landing. There's a question that just came in asking if we will share our slides. We'll absolutely do that. We'll send that out to all attendees. We'll also send a link to the recording. If there's something in here you wanted to go back and listen to again, or maybe even to forward or share with a colleague. I would also mention that we're going to repeat this live webinar tomorrow. We're going to do another session just like this tomorrow afternoon at 2 p.m. Eastern. So if there's anyone within your facilities that you think would benefit from hearing this, feel free to invite them. If you're not sure how to do that, or if you need something from us, let us know. But we are going to do this session again tomorrow. So thanks everyone for your participation and for tuning in. Thank you to our panelists. Very, very interesting information that was shared, very relevant and helpful. So we appreciate everyone's time. Hope you have a great day. And again, please stay safe and well. Take care.
Bye, everyone.